Now, I'm pleased to introduce our next speaker for this session. Dr. Frans J. Cronje, MB, CHB, MSc, BSN, is an aviation medical specialist and the founder of the Department of Biomedicine at the King Hamad American Mission Hospital, KHAMH Bahrain. His pioneering work in mental health focuses on neuromodulation with particular interest in transcranial electrical stimulation and neurofeedback, and their applications to stress-related disorders and brain-body regulation. He is both certified in neurofeedback and has developed a structural clinical neuromodulation service integrating neurotechnology with systems-based approach to the gut-brain axis. The paper focuses on some of their work on applied neuromodulation and system-based approach to stress-related disorders, integrating transcranial electrical stimulation and neurofeedback within clinical practice. The presentation title for this day is The Neuromodulation in Stress-Related Disorders, Clinical Experience with tDCS and Neurofeedback. Over to you, Dr. Frans.
Good morning. Yes, my name is Dr. Frans Cronje. I'm head of biomedicine and an aviation medical specialist. And in our aviation, hyperbaric, and advanced wound care practice, we see many patients with mental health challenges. And for many of them, for instance, pilots, pharmacological solutions are not compatible with flying safety. So we've had to expand our service towards neuromodulation. As such, our group focuses on applied neuromodulation and systems-based approaches to stress-related conditions, integrating transcranial electrical stimulation and neurofeedback within a structured clinical service. And today I'll be presenting our work titled Neuromodulation in Stress-Related Disorders, Clinical Experience with tDCS and Neurofeedback, with a focus on its relevance to gut-brain axis dysregulation. So our study's rationale and the research question was, can modulation of dysregulated brain states within the gut-brain axis produce clinically meaningful improvements across stress-related domains? Stress dysregulation manifests with many downstream effects. So the central question is whether targeting dysregulated brain states rather than diagnoses offers a more effective intervention framework. The gut-brain bidirectional system has been addressed several times this morning, and it connects, as we know, the cortical regulation with autonomic pathways and gut signaling. And disruption affects many domains, and by focusing on regulating them, one can shift the frame of our intervention towards restoring regulation rather than suppressing or addressing symptoms on their own. Now, by way of introduction, transcranial direct current stimulation provides low-intensity electrical modulation of cortical activity, typically targeting prefrontal regulatory networks. It alters cortical excitability, so it doesn't discharge neurons, it raises subcortical potential and therefore makes them more ready to respond through a neuroplastic process. Clinically, it's non-invasive, well-tolerated, and relatively easy to deploy. Complementing this, we implemented neurofeedback as an active self-regulation approach. So here, using real-time EEG, individuals receive continuous feedback on their brain activity. For example, watching a movie that dims and brightens, depending on whether their brain activity is moving forward or away from the desired pattern. Through this process, the brain initially is conditioned involuntarily, but through operant learning, the individuals ultimately gain voluntary control over their brain states. And across repeated sessions, they learn to reinforce these adaptive patterns. And this positions neurofeedback as a training-based intervention that complements the more massive modulation of transcranial direct current stimulation. So the methods of this study, it was a retrospective, observational analysis of a clinical neuromodulation service. The sample included 26 transcranial patients and 48 neurofeedback patients, with a subgroup of joint receivers of the interventions. The focus was feasibility, tolerability, and real-world implementation. So this represents our 18-month real-world data set. Across more than 500 sessions, we captured a substantial exposure profile under routine clinical conditions. Delivery followed structured protocols with continuous outcome monitoring, and most clients completed more than 6 sessions, with 5 being considered the minimum therapeutic amount, indicating good adherence. As a retrospective observational data set, this provides at least strong ecological validity while retaining an inherent limitations of a non-randomized design. All interventions were delivered within established safety parameters and no serious adverse events were observed. This aligns with broader regulatory developments, even supporting the use of these devices at home, and therefore makes the interventions scalable. So in terms of outcomes, we observed consistent engagement with the majority of individuals completing 6 and more sessions. This supports the feasibility of both modalities in a real-world setting. Our population was surprisingly heterogeneous, including from pediatric to geriatric patients. This reflects broad applicability across clinical domains. The indications mainly clustered around mood and stress disorders, some with mild cognitive impairment, and then a few children with neurodevelopmental challenges. These domains align very closely with systems typically implicated in regulatory dysfunction. Now, neurofeedback required slightly more sessions than transcranial because it is a learning paradigm and therefore does inherently take a little longer. Clinically, though, we observed consistent patterns of clinically meaningful improvement across the functional domains, particularly related to stress regulation, emotional stability, and cognitive clarity. These improvements were observed alongside high adherence rates of at least 2/3 of our clients. Notably, these domains correspond with gut-brain axis regulation aspects, including autonomic balance and neuroendocrine signaling. And we're quite excited about transauricular vagal nerve stimulation being an extension of the electrical stimulation family, which we are looking forward to introduce shortly. So interpreting these findings, they are consistent with the systems framework and align with models of neurovisceral integration. Transcranial direct current stimulation likely contributes through modulation of the prefrontal networks, supporting a top-down regulatory control. Neurofeedback enables bottom-up regulation through adaptive learning mechanisms. And together, these approaches may facilitate restoration of balance across neural, autonomic, and inflammatory systems. The combined modality also suggests a possible synergistic effect, but this needs to be formally evaluated. Importantly, the FDA approval now of home-delivered devices makes it scalable and decentralizable. So in summary, neuromodulation appears feasible and well tolerated in real-world clinical settings. These interventions target core regulatory systems rather than isolated systems. They show potential relevance for conditions involving gut-brain axis dysregulation, and future work should focus on objective biomarkers, standardized outcomes, and evaluation of combined and home-based approaches. In the few moments I have left, I actually anticipated 6 questions which may have general relevance to the audience and may assist in just answering the broader, most likely questions. And the first is, of course, this isn't a controlled trial. How do we interpret efficacy? It was, as I mentioned, a retrospective observational data set, but it's meant to inform hypotheses and generate abilities to conduct future controlled trials. How do we separate placebo and expectation results? Well, the interesting thing is that patients don't actually know what to expect, and therefore seeing consistent changes over domains, good adherence, and alignment with changes in known regulatory systems, it does suggest a physiological component. And there are truly a vast number of randomized controlled trials. And in fact, even our devices make provision for sham trials. And that's why FDA approval has also been given. So why gut-brain axis? Well, the mood, cognition, and sleep aspects map very closely to the systems regulated through gut-brain axis. How scalable is it? Well, at least transcranial direct current stimulation may become significantly scalable, with a home use being possible. And what should we do next? Well, of course, a structured prospective work with standardized outcomes measures and ideally biomarker correlation. Why not use standardized scales? Well, we plan to do so, but for now we prioritized real-world clinical observation and service implementation. So with that, if there are any further questions, I'd be delighted to take them.
Thank you, Dr. Frans. The most beautiful thing was you already anticipated the questions and you have already given them the answers. So that was incredible, great. There is one question, Dr. Frans, in the question and answer session. Ms. Wendy Jones is asking, it's a fascinating piece of research and she thanks you. And she also asks that when do you plan to roll out the next phase?
Well, the next phase, of course, the service is ongoing, but what I'm really hoping is that I might today involve some of the people involved in the mental health field to become part of our clinic's work. We really invite you to come and see what we're doing. And in fact, we would like to draw up the next and future studies with your collaboration.
Thank you, Dr. Frans, for answering that question. I'm sure it has answered the question of Ms. Wendy. So now, before we move on to the next speaker, so thank you so much, Dr. Frans, once again for sharing your expertise on the neuromodulation and its application in stress-related disorders. Your work offers valuable insights into innovative clinical approaches. So thank you once again, Dr. Frans.